Welcome to the unknown, or the soon-to-be-known. Fabulous presentations, thank you very much, and maybe we can stand, I guess. Yeah. Yeah, that brings a lot of or omics, I guess.
Could I ask a first question to Justin?
Of course, go ahead.
Just because he mentioned very beautifully metabolomics. And I very much agree with what you said in terms of the power of metabolomics. But let me say today, metabolomics on its own is not going to give you useful outcomes to change the way you do your clinical practice on its own. So what we need is the combination of these things put together, and that is going to give us the closer to the result. Because what we get from metabolomics is an individual signature of an individual, but it won't tell you how someone gets ill and who's going to get ill, unless you have all of the other bits that are missing.
I agree. It's just more expensive if you add something else.
But it's but that's also very true. But it's getting so much cheaper. So much cheaper. Now, in terms of the genomic side, what I showed you in that platform, $100, and in the next 5 years, it'll be $10. $10. What clinical test can you do in your clinic with $10? You can do very, very soon the whole genome.
So, since there are no questions on Slido, because you've been very, very attentive to the speeches, well, first question, I guess, to Yanis. In exercise medicine and in patients whom we know to be insufficiently active and they would benefit to be more active and to have better fitness levels, should we care to know about their genetics before we tell them to move more, or just simply tell them move more?
Absolutely. Think back to that Bouchard's heritage study. Did you see those individuals? They're not one or two. They're getting worse. They're getting worse. Not just maintaining, they get worse. Why is that? But what I'm not here to sell you is doing just the genomics. That's not going to give you anything. What you need is, what I've tried to get across, is going from the code to care. Point number 7 on the slides that I put. That's what we need. So yes, I'd argue we do. Also, to avoid the situation that you're prescribing the exercise, but you're prescribing the wrong exercise. So how do we individualize the exercise, the treatment from that, the side effects of the exercise? You know, some are gonna, why would you choose running, for example, in someone who's predisposed to have a tendinopathy?
So, but to follow up on that, we know from some of the studies of Bouchard and others that you may have a different trainability for VO2 max, depending on your genetic background, or for strength as well. And they're not the same. So if you're not very trainable for VO2 max, you may be better trainable for strength, for example. How do we know that and tell them to not do too much of the exercise that they're not really designed for?
Look, I think exercise is, I know you've chosen exercise, and clearly one size fits all is what's happening now, and the problem is, by the year 2050, 60% of the world population is going to be overweight and obese, so it's not working anyway. So I'm not saying let's rush into the genomics to solve the problem, but even there I think it's going to be important. I would like us to come back to the things that you face every day in your clinics, which is how do I personalize my treatment so that method A, B, C, D, E, the ones that we've heard over the course of these 2 days, is the right one for your patient. And you don't end up having problems that associate with the intervention, whether it's exercise or whatever. But I think for exercise is medicine, or the kind of getting the world to move, I think we have bigger problems, and it's not the topic of today, but if I was to summarize it in one sentence, it's a problem of implementation of great policies. That's the problem, and it's not a genomics or omics problem.
I just want to catch up with that question before I want to go to Justin again. You know that in Switzerland the prevention is cut down by the Ministry of Health, and that's a really big disaster. So
huge.
If we look at what you are saying, I think can you tell about the need for structured exercise guided by experts in the society, or is it just enough to say, oh, everybody goes and so there's no support needed?
I mean, what I've just heard from what you said in terms of the government, let's say, moving away from the prevention side is catastrophic. And I think we can learn lessons from Asia, where the population is so huge that the National Health Service cannot deal with it. So that is why the investment now is on the prevention side, whether it's for the exercise or for other disorders that will come. It's absolutely essential, and that's the only way countries like India, countries like China are having to deal with this pandemic which is here. It's upon us. So unless we adopt these kind of approaches and start doing the research properly, which is, and by the way, when I presented what we should be doing, I'm not saying I'm doing that, but that's what we have to be doing. And that's the only way we're going to deal with what's coming, because we're not going to be able to cope. And if you, those of you from the UK, I don't know if anyone's in the UK here, recently the government announced that they're going to collect a blood sample from every newborn. And that's going to be in practice over the next decade. That is what Switzerland needs to do, not to go away from that. And I can sense the arguments. During COVID, we heard that whole debate. Do we give everyone the same vaccine or whatever? Clearly, it was a different time. But now with what is coming, we need this approach, but moving away from just one of those omics and using the power of AI. And I went over it very, very quickly, learning from our patients. When the patients go out into the community and are doing what they're doing, we should be learning from their treatment. The treatment should be ongoing. That's why you heard there the P4 program. The patients are participatory. They are part of improving their treatment. They are involved in their treatment, rather than everyone gets the same treatment, go away, and good luck.
Thank you. That's a big support for us. And then going to the other spectrum, to the athletes. I personally cared for athletes in the past, for really elite athletes in swimming. And I experienced that these athletes got into the overtraining when an additional challenge was there. For example, they were successful, and then they got into contact with the media, and they had more and more dates. So should it be necessary to educate the elite athletes in order to be sensible for the overtraining syndrome and for the symptoms to that? Are they able to detect that earlier if you would educate them? Because I don't know about that.
Yeah, probably. And not only the athletes, but probably the coach and the coaching structure as well. I think in some environment it's still difficult, but sometimes the coach do not believe in overtraining. They say, or they're just lazy, or it's in their head, or they have to push themselves a bit more, no pain, no gain. So yes, I think it's important. And by the way, that's the same for REDS, right? We also need to educate athletes and coaches about REDS, that is a thing, that it's dangerous. And it's always the same thing. It's better to prevent than to treat.
Can I just add to what I just said, if I may, very quickly? Over 25 years ago, we published our first paper on chronic fatigue syndrome and looking at that whole serotonergic, dopaminergic system. I moved out of that field because we weren't coming up with a diagnostic test. Was it mitochondria? Was it this? Was it whatever? And the coaches in the audience will know. What do you do with elite athletes? You push them as much as you can, just beyond their breaking point. But you don't know what their breaking point is. So what we need is to convert the wonderful presentation we heard from Jace into technology and a toolkit that we can use to know when you're going to go just off the end of the cliff. But you're right there because you really want the athlete, when they cross the line, to crash. But after they cross the line, not just 1 meter beforehand. And that balance requires the kind of things that we talk that we need to do, or else we're not going to change the field.
Yeah, so to build on that, I was going to ask a little bit about wearables and metabolomics, or what's happening inside and what we measure. And you showed us a video from the marathon and little dots that were getting redder and redder. So what were the metrics? What were the wearables? And what were the genetics behind it, or what are you looking at?
Yeah, that particular one, I was trying to show you the phenotypic side. So at that stage, the genomics is not involved. But what you had there, because we were looking at exertional heat stroke, I went over so quickly you wouldn't have even noted. That was actually a race in Singapore. So you can imagine what the temperature's like, very hot, very, very humid. Supported by the Singapore military, who basically want to deal with exertional heat stroke every year. During the training of soldiers, one person will die during training. These are very, very fit people, going back to the question about exercise. They're incredibly fit people, but they will die by doing training in the heat, and you can't predict just based on core temperature. So the metrics we had there were ones geared towards exertional heat stroke. So we had core temperature, we had skin temperature, we had IMU in the shoes to get also the kind of the biomechanics, because you can start identifying when someone's running style starts changing. My point is that the way the field is going is you're combining sensors based on what your phenotype that you're interested in. We were discussing earlier, we have the National Games of China happening in a few days' time. There we have in boxing, because those of you interested in boxing will have known that in August this year, 2 boxers died in one competition in Japan. And so in boxing, what you have is smart mouth guards who actually, you're getting how hard they're being hit, and you link that with the biometrics that you have and identify, and also that also helps us in terms of the concussion and other aspects as well. So it's combining the genomic and the other omics with the phenomics, and then I think we'll have transformation that we didn't get from the Human Genome Project. But for that, what we need is overcome a big problem, typically related to money, which is the problem of average thinking. We have to think big. And at this conference that I've just come from, we had James Watson speak to us from the US saying, think big, think high. And that means, comes back to my final point, is we have to work together to do those kind of studies. So Jason, the one that you presented, for example, let's do the other omics together. You're doing the experiment, let's do the other omics together, or another lab. It's working together. That's what we learned during COVID as well.
Okay, so Justin, coming from the audience, somebody wants to know a little bit about, once you've identified OTS, what do you do, as far as recommendation, management strategies? And I would add to that, can you imagine measuring some things that we currently don't really yet measure in the field of mapping metabolomics that will help to guide management and loading of the function?
Yeah. So I think the official recommendation is to start with 2 weeks of complete rest. And then you have 6 weeks of partial relative rest. It means if you're a swimmer, you're not allowed to swim, but you can play badminton with friends, for instance. Yet in reality, it's difficult because sometimes they don't want to stop for 2 weeks. So I think we need to have the athletes, the coach, and the team buying in the diagnosis. Most of the time, you can just tell them, okay, look, if you don't change anything, it has been going wrong for months. If you don't want to change anything, maybe you can continue training and have bad performances for the next month. But if you came to see me, probably it's because you want something to change, right? So let's start the change today. And I think most of the time, it's like a negotiation. You need to reduce a bit the load. Most of the time, it's not possible to stop them totally, and you need to take the context into account as well. Sometimes they have a very important meeting or very important competition coming, and then they can try, right? You can reduce the load by 50% and let them swim in 3 weeks and see what happens. And in terms of metabolomics, I think metabolomics or other omics can help for 2 things. The first one is to better understand what are we dealing with. So to better understand the pathophysiology, it's possible that we will detect biomarkers. The best will be to have a biomarker that you can detect at rest. Because I've been in Brussels, I've spent days with athletes doing this 2-bout exercise protocol. So they arrive in the morning. Actually, they arrive the day before, so they don't have the stress of traveling, and it's the entire day. So it's very long. It's very expensive, not in Belgium, but in Switzerland, that's not something we can do. It's too expensive. So it will be very easy if we can just do a blood test and have a biomarker. I don't think it will happen because many people have tried and they failed. So maybe we can have like a kind of combination of markers that could help. Yeah, and there are other things like HRV, for example, that is useful if you have a baseline. If you do it for the first time when the person is already very tired and overtrained, it's not going to help a lot.
But Jason, imagine having those measurements when they're well. The problem is they'll come and see you when they're unwell.
Yeah.
What we need is all these markers when we are feeling fantastic.
Yeah.
That's when you want those markers.
Yeah.
And then when you have the issues, it'll be individualized, because in terms of the metabolome in our anti-doping work, with different drugs like EPO, you get individual metabolomic signatures, but my metabolic signature of EPO will be different to your metabolomic signature of EPO. That's why it winds up in a court of law. So we need to look at the data when people are healthy, get those responses, And then when the person's getting unhealthy over time, that should be real-time determined through, and I can promise you in the next 5 years, the way we're measuring blood glucose in our homes, you'll be able to do these omics things in your home, the size of a mobile phone. Already, the genome was sequenced in space. It's been sequenced on Kilimanjaro. You know, this is happening, which means we have to be ready for sports medicine that's coming and sports and exercise medicine that's coming.
Excellent. Well, thank you very much. I mean, I see some of the questions here. You want to know, what can we do in practice setting? And but it's coming. I mean, you heard it. We're going to get these tests of all of these different individualized parameters to get those individual signatures in the future. So great session. Thank you, Arno, for being here with me. Thank you, Justin. Not Jason, and Yanis as well. Yanis, I know that you've got to get quickly to the airport, so you've put your running shoes on so you can get there in sub 2 hours. I'm pretty sure you know very well how to do that. So thanks a lot for being here, and thank you for the audience.
Thank you. Thanks a lot. Thank you.